Okay, because it's already at 10, so I will start this lecture. Prof. Aljunid, I will start now. It is okay?
Yes, please. Yeah, we'll have a 1 hour. Yeah.
Okay, yeah. And for information, this lecture also live in YouTube. Okay. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. And hopefully we are in the healthy and good conditions. And thank you for joining in today's virtual guest lecture. Today's lecture is a part of Reformasi Pelayanan Kesehatan or Healthcare Reform lectures. The lecture is the one of lectures in the Public Health Science Department, Faculty of Sport, Universitas Negeri Semarang. And before we start this lecture, please let me inform the rules of this lecture. And this is the rules for these participants. Okay, the first one, please turn on your camera and turn off your microphone. So please be on cam. And then the second one, please change your display name for the Zoom with the format, name, and your institutions. Okay, and then please behave appropriately during the guest lectures. And the fourth question can be asked directly after being allowed by moderator or through the chat menu. I will ask you to ask directly after the Prof. Aljunid finish the presentations. And then in the end of virtual lecture, it will be informed the URL of a certificates issued, so do not leave the Zoom. And the last one, the link is active for only 60 minutes after this guest lecture is over. And for information, this lecture also streams in YouTube channel named Prodi Kesehatan Masyarakat UNES. And today, we are pleased to have a great opportunity to have a great guest lecturer, Prof. Dr. Syed Muhammad Aljunid. He is a professor of Health Economics, Policy and Management, Faculty of Public Health, White University. He is an expert on health policy, health economics, and financing. And before we learn from Prof. Aljunid, please our Vice Dean of Academic Affairs, Dr. Mahlul Asam, for giving welcoming speech to Prof. Aljunid. Dr. Mahlul Asam, please.
Thank you, Bu Lala. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Good morning, Prof. Syed Aljunid. Very happy to meet you again virtually. Also, we say welcome to our lecture. I saw here Bu Intan, Pak Lukman, and others. Our student in Universitas Negeri Semarang, as well as Prof. Syed student from Kuwait, maybe, and from Malaysia as well. We are welcome in this lecture. Yeah, once again, thank you very much for accepting our request. Prof. Syed always support us in collaboration, in visiting lecture, in research collaboration, and other academic activities. We are very thank you, and On behalf of our faculty, we thanks again for this collaboration, and we hope this collaboration still continue to improve our academic collaboration in the future. Our Dean, Prof. Tadio, sent her warm regard to Prof. Syed. She actually want to join in this morning, but she have to go to Jakarta in another agenda. So she sent one regard to Prof. Syed and all of us to join this virtual lecture. Today we have very very interesting and very important topic: health system reform, lesson learned from major initiative in developing countries. We believe that this topic will very fruitful to us, to our students, in the insight of and sharing from Prof. Syed Aljunid, that have very experience in this condition. Once again, enjoy the webinar, the quiz lecture, and thank you very much once again to Prof. Syed and all audience. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Okay, thank you, Mr. Asam, and also I would like to say thank you for all participants from the Bachelor and Master student of Public Health Science Department, Universitas Negeri Semarang, and also the lecturer from Universitas Negeri Semarang. And also in here, there's also the students of Prof. Syed Aljunid from the Faculty of Public Health, Syed University. And it is now my pleasure to introduce our guest lecturer, Prof. Syed Muhammad Aljunid. Good morning, Prof. Aljunid.
Good morning. Good morning. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much that you are want to share your experience to our students, Prof. Syed. And then now introduce myself. I'm Kafila Maharani. I'm also a lecturer in the healthcare reform lectures in Public Health Science Department. And now, before I start this lecture, I will read the curriculum vitae of Prof. Syed Aljunid. Okay, and this is the curriculum vitae of Prof. Syed Aljunid. The previous slide, please. Professor Dr. Syed Muhammad Aljunid. He is a professor of health economics, policy, and management, Director of Postgraduate Programs in Department of Health Policy and Management, Faculty of Public Health, Syed University. His education background is Doctor of Medicine from University Kebangsaan Malaysia, Kuala Lumpur, Malaysia, Master of Science, Public Health in Public Health, National University of Singapore, Diploma London of School of Hygiene and Tropical Medicine, London, the UK, and also the Doctor of Philosophy in Health Economics and Financing, London of School of Hygiene and Tropical Medicine, London, UK. And his research interest is healthcare system in developing countries, health policy, health economics, and financing. And he has many international awards, but I just read some of those. As tokoh ilmuwan Darulaman, Perbadanan Perpustakaan Awam Kebah Sampena dari Hari Buku dan Hak Cipta Sedunia 2019, Force and Sullivan Award Malaysia Healthcare IT Company of the Year 2017, Cosmic Solutions, SND BHD, International Society for Pharmacoeconomics and Outcome Research, ISPOR, Distinguished Service Award 2016 by ISPOR, and UKM Vice Chancellor Special Innovation Award 2014, Anugerah Tas Inovasi Naib Counselor UKM 2014 for International Cosmic and Clinical Coding Center. And he's also have patent and copyrights like CBG's Cosmic Trooper software in 2018, ECPPS, an integrated care pathways for management of post-stroke residing at home in the community in 2016, and Stroke Case TM, Home Care Modular Training Program for Stroke Cases in 2015, and INA CBG's Cosmic Grouper software for Indonesia in 2016. So I think the student in the public health already know about the INA CBG's also. So it's a great opportunity to see Prof. Syed Aljunid in here. Okay, and today Prof. Syed Aljunid will be shared about health system reform with the topic health system reforms lesson learned from major initiative in developing countries. And with, for the participant, please turn off the microphone. And Prof. Syed Aljunid, please you can share your slides.
Yeah.
Okay, and the screen is yours. Thank you.
Thank you, Dr. Chatila. Thank you, Dr. Mahalul, for inviting me to speak and deliver this special lecture to students in Indonesia. And we also share this presentation with my students in Kuwait, and also some of my students in Malaysia, and also my colleague in the Malaysian Health Economic Association, and also other affiliated organizations in Malaysia. So thank you so much again for inviting me. I will try to share my experience and observation on looking at the various reform initiatives in developing countries. And I choose a few countries, of course, Malaysia, and then one of the countries that I will present. And we will also talk about countries near us, for example, Philippines, Vietnam, and then we choose another country, which is Mexico, which is quite far from us. Anyway, these are some examples. I will talk about the theoretical aspect of health sector reform first, and health system reform, and then we'll go into more detail afterward. So I will share my screen now. I hope the line would be nice to us today, because last few days we have quite unsettled issues on the internet line over here. Okay, I will try to talk about the definition of health system reform and why we need health system reform. I will actually use health system reform and health sector reform words interchangeably here, because before this, people were focusing on the word they use the word health sector reform. But to me, in my lecture, I will not differentiate these two, but I will consider this the same. We'll talk about the conceptual framework and factors that trigger the health system reform, and after that, we'll go into this case study, the 4 case studies that are available for us to explore, and information has been some information has been published, and what can we learn from this reform. So quite some time back in the early 70s, WHO CRO, for example, defined health system reform as a sustained process of fundamental changes in the policy and also in the institutional arrangement related to health sector. And when Peter Berman wrote his paper on health system reform, he added up a few more words. He added up he include in this definition the purpose of a health system reform, which is actually to achieve 3 important goals in health system, which is efficiency, equity, and effectiveness. So all this actually part and parcel of what has been sort of organized and put it as a package, when World Health Organization launched the Universal Health Coverage Initiative back in 2008. So if we can differentiate the different type of health system, we can divide at least in two broad categories. The first is health sector reform, which actually define, it includes the broader reform within the health sector, which is the looking at the policies, and then what is the existing policies, and then the various component of the health system that are involved. And then there is another broader form of reform which cover not only health system but other ministries as well, and other departments, other sectors as well, which is called healthcare reform. And this might involve other social sector as well. One of the researchers in Global Health Action published this conceptual framework on the interface between the health sector reform and the country health system. And if you look at the center here, this is where the health system component, and the health sector reform might actually cover many or all these 6 components, or might only cover 1 or 2. So William Xiao from Harvard University described this as the what he said the different knobs in the health system reform. So he differentiated into 2 types: the big reform and a minor reform. Major reform, or they call it the big R, will actually includes the reform that covers many components of the health sector reform that might cover all these items. This means that it might, from the health financing perspective, it might cover issues like the development of financing packages, the provider payment method, and then the effect on the reform on the community or on the population. Whereas a small reform, which is called a small R, or small minor reform, might only touch maybe 1 or 2 components of it. Maybe they look at only the governance, or they only look at the health workforce, for example, but not cover a lot of these things. So this is way that, and of course, all these will have effect on the people that are providing the services as well as receiving the services, which would have an impact on the overall health service delivery and also health outcome. So this is quite a useful conceptual framework if you want to study the health sector reform or health system reform. At least there are 3 main reasons why health system reform occur, or why reformers in the health system try to reform the health system. Number 1, of course, it is a response to inadequate access to healthcare services provided by the players, by the most of the time Ministry of Health in most countries, or there is an insufficient amount of resources which are required for the provision of the services. And also another important aspect is related to the people response to the services that are given. If the services are not responsive, people are not satisfied, this can be an important reason for the reforms to take place. So when we talk about inadequate access to healthcare, it includes issues because of the poverty in the country, huge differences in terms of the access to the services, which are affected by the income and also the population's ability to pay for the services, and other things such as gender, and also age differences in access, and also the lack of proper planning for the health services. So when we talk about inefficient use of scarce resources, this relates to a fund that are provided for healthcare may not be adequate to cover different level of healthcare services, primary, secondary, and tertiary, or the way that the resources are being allocated might be skewed towards a certain component. Maybe in many countries, there were a lot of emphasis given on curative care rather than preventive services. And when we have, even currently during the pandemic of COVID-19, we can still see that the first initiative that was taken by most countries is actually to focus on the hospital, which is the curative services. And this actually might lead to a lot of issues on getting enough resources for preventive and also health promotion. And then poor quality services might have an important impact on the way that people see the services and people use the services. In the public sector, we know that in most public sector, in many countries, there's a long waiting time. The staff are not that motivated to work because maybe they were paid a very low salary. The office hours for the services might be very short. Whereas in the private sector, people may not have to wait long. They might be able to see the staff or the doctors anytime, but of course there are issues related to financial exploitation, and then the staff might be employed, but they were not properly scrutinized in terms of their qualifications. And even in some countries, private sector provides services which are dangerous to the people because they were not qualified to provide the services. And I think we can see that in many countries now, there were a lot of issues where the private sector provides services which are not actually healthy to the population, including services that relates to the aesthetic and also beauty services. There was actually a lot of medical procedures were involved, and this endanger the population. In most countries, there are a number of issues, there are a number of trigger points that actually leads to the health sector or health system reform. In countries that depends on donors, donors might actually stimulate or influence the reform that they see suitable for them to go in and also to provide the funding. And reform in public or civil service is an important component that might trigger the reform in some country when the government want to change the way that services are being delivered, or they want to say, for example, improve the quality of the services. There are also other things like, for example, the change in government. In Malaysia, for example, we have changes in the government last 2 or 3 years with a rapid change because of the change in the election outcome, and these have a lot of impact on the some of the reform that was created or that was initiated by the government that lost power during the subsequent election. And of course, major challenges such as the pandemic that we are facing now can be an important stimulus to trigger the health system reform. And of course, we cannot deny that development in economics of health and also in epidemiology, for example, and in public health services, and also subject on the whole, which creates more innovations and also information that can be used to improve the system, can be a very good, important trigger for the health system response. We can see that when we talk about the influence of major donors, back in the 80s and also the early 90s, World Bank plays an important role in actually introducing what we call the structural adjustment policies that leads to a lot of issues, and these affect many developing countries, especially in African region, through the reports called for Agenda for Reform, which actually translated or contain reform initiative that being promoted in this country, which includes introduction of the user fees in public services, privatization of certain services, as well as decentralization of the services. Yeah. So in 1987, this is one of the major reform initiatives which are created by World Bank, and they tried to introduce these 4 major changes in the health system, which actually has been going on until today. Some of the initiative actually leads to disasters in many countries. For example, the introduction of the user fees, and also some of the issues related to decentralization. And the third point, which is effective use non-governmental services, which is basically privatization of the public services. And World Bank also influenced the development or promotions toward the establishment of hospitals which are independent. We call it autonomous hospital, and also the introduction of managed competition in the 90s. Some of these reforms are still going on in many countries because of the influence of the major donors. Some of it actually has been stopped because of the major problem that they are facing. In terms of the reform of the public services which affect health system, this includes because most of the countries, the main health service provider is Ministry of Health. When the services, civil service, want to reduce the size of the population, size of the workers, it might have a major change in the reform. And in Malaysia, we are having this problem at the moment because we have many doctors that has been trained, but they were not able to be absorbed in Ministry of Health, and they were given, instead of a permanent position before, the government offered them what we call the contract services with a short period of time. This may not be to their liking, and this leads to a lot of issues in the health system currently related to human resource. When we talk about the economics of health and also development within the discipline of public health, the introduction of the cost-effectiveness methods, economic analysis method, and also evidence-based can be a major problem, a major sort of stimulus that might actually leads to this. And then WHO before and now being taken over by Institute of Health Metrics started what we call the studies on global burden of diseases, which actually influence quite a lot of activities and also ways the health system is being managed in many countries. This is the 4 countries that I would like to share with you some of my observation based on my interaction with some of these countries and also what we get from the literature. Mexico is one big country in the South American region, which started some of the initiative a few years back. Vietnam, which is within, and Philippines within our ASEAN partners, and of course, what happened in Malaysia before. Mexico, as I mentioned, with more than nearly 130 million people with a per capita GDP of 8,000 plus, started its health system reform as a result of the report that highlights the situation of catastrophic health expenditure. So for those who have not heard about this terminology, catastrophic health expenditure means that the population have to spend a lot of resources, which actually leads to the depletion of the resources, and that can lead to poverty. So this is the situation that affects nearly half of the population of Mexico back in 2000. And the main problem is because of the social inequity in the population, and also the chances of the population to be employed and the lack of opportunity that are available. So what the government of Mexico did to respond to this is to introduce the systems of social protection, which is basically a major reform to provide the health financing system. So this is a major reform. And within that reform, they introduced something which is very targeted towards the poor, which is called the Seguro Popular. This is actually an innovation that created as a subset of the overall social protection program that provide coverage to all people that are not covered by other schemes within the system. So anyone who are not covered by the social protection, which is a social security or social insurance program, will be able to be enrolled. And it relates to the way that Seguro Popular work is that they provide the voluntary health insurance, and this voluntary health insurance can eligible to be enrolled by people who are not covered by the system, and it provide a free services. So the funding actually comes from planned to be actually from 3 different sources: the federal and the state government, as well as people will pay a premium to that. 5 years after it has been launched, I think in year 2005, it was found that it was investigated that reported that the Seguro Popular scheme have been able to, it has invested about $1 million US, and 3/4 of the resources come from the federal government and only 25% from the state government. The plan to get it to get the people to pay the premium does not occur. So the families do not actually pay for the premium, maybe because they are too poor to come in, or maybe there are weaknesses in the system. And the services was quite well covered under this. There are more than 266 health intervention and more than 300 type of drugs are covered. So 15 years after the implementation, there was a study that looked at the trend. It shows that it gives a lot of positive impact on the whole outcome, on the whole population of Mexico, especially the poor. There is improvement in terms of the access to health services, reduction in out-of-pocket expenditure, which is a major problem that leads to catastrophic expenditure. In the early in the report of year 2000, it was produced by WHO, and also there was actually reduction or protection of the poor from going into a more severe economic condition. So this is one of the success stories that happens in Mexico, and of course it leads to quite a big reform in the system. Another country that actually also reformed the health system is Vietnam, which is close to us in Malaysia and Indonesia. And I was fortunate to be able to work with the Vietnamese Ministry of Health for quite some time in the early 2011 to 2014. And this country, actually, Vietnam, previously it was under closed economy because of the communist way of managing the country. They have opened up quite a lot. The population of Vietnam is close to 100 million, and the main source of expenditure when it was the reform was thought to be important is because it comes from out-of-pocket expenditure. So people have to pay out their money when the country opened up from the closed communism way of managing communist economy. In 1992, the country developed or introduced the social health insurance. It's one of the early countries in the region that actually introduced social health insurance. And within the social insurance, there is a special insurance which was created to cover the poor household and the disadvantaged group, which is called the Compulsory Health Insurance for the Poor, HCFP. And the eligible population are the poor, social protected groups, and also elderly, the elderly, as well as people who are affected by the Vietnam War in the 60s, which are related to the use of the dioxin or the orange agent. So this insurance for the poor, if you compare with Indonesia, this is almost the same like Jam Kesmas that we developed before. So I was involved in development and also Jam Kesmas before JKN was introduced back in the early 2000 to 2000 and before 2000 to 2014. This is where the INA CBG, which we see today, which is the provider payment method, was actually introduced. Before we used another case mix system, which is called the INA DRG, which was used for the Jam Kesmas in Indonesia. The healthcare funding for the poor in Vietnam was actually designed from the start to be 100% funded by the government. So this is the same, I think, for Jam Kesmas in Indonesia, where the money comes from taxation. Before we introduced, or Indonesia introduced JKN in 2014. So for every beneficiary, they receive the funding, which are allocated by the central and the provincial government. The central government pays $2.5 US per person per year, and 0.84 dollars per beneficiary by the provincial government. The benefits are quite a lot. They get the outpatient, inpatient services as well as laboratory services, and they don't have to pay anything. So by 2009, 15 million people out of the 100 million in Vietnam are covered by this scheme. And they have a very positive impact on the reduction of the out-of-pocket expenditure, which is the main trigger point for the Vietnam to actually move into social insurance program. But there are some weaknesses in the system that has been reported. Number one is that they were using fee-for-service reimbursement, which actually leads to many problems. One of the problems is that it leads to the classical issue of supplier-induced demand, where the physician tend to overtreat the patients, and then the system have to pay quite a lot of resources to this physician. And then the government came in to actually introduce this. Since 2003, the social security or social insurance program in Vietnam has absorbed the health care insurance for the poor, and they manage it. And they make a proposal to actually change the provider payment from fee-for-service into the capitation for the primary care and case mix or the RG system. So I was there actually to work with the Vietnamese government back in 2011, 2013, and where we helped them to design the case mix system for Vietnam, which is being used currently. Philippines, another big country in the region with 109 million people, and this is a huge country, and it contains 18 administrative regions with a per capita income of over 3,000 US dollar. And the current growth rate, as many other countries in the region, is negative. And this is because of the COVID-19 pandemic before, negative 3.5%. In Malaysia, our GDP growth last year actually constricted to minus 5.6%. It was reported. In 1995, Philippines government introduced a major reform, actually to try to achieve universal health coverage by the target of 2013, and they introduced this health insurance program, which is managed by a government agency, which is called the PhilHealth or Philippine Health Insurance Corporation, and it covers, as you know, Philippines, they send a lot of people work outside the country, so it covers even people who are working outside the country. But of course, the major enrollees are the formal sector workers, the poor, and also the retirees. So if you look at these enrollees, I think nearly more than 1/3 of the populations covered under this are the poor and those working in sector in the formal economy. If you combine this, is more than 70%. The rest are those working in the informal economy, the senior citizen, and other people that are sponsored. So the situation in Philippines was that they have a premium, which is actually paid by the employer and employees' contribution, which is 2.5%, a maximum of 3% of the salary. And then the indigents, they get their premium is paid by the government, which is about 2,400 pesos annually. These, I think, last few years it might change now. And people who are working in the outside the country, OFW, they actually the overseas foreign workers. They pay for sea-based, those who are working in the with the ships and also with the services that are provided by in the cruise ship and all that. I think they pay 2.5% of the contribution, like the formal employees. Those who are working land-based, about 2,400. So the premium are being paid, and they provide quite extensive benefit package, which is quite good. They provide inpatient care up to 45 days per year. Of course, if you compare with this South Korea have got a much more bigger benefit. They cover, I think, nearly about 200 days of inpatient care. So the benefit package, although it's quite it covers up to 45 days per year, is quite extensive actually. In terms of purchasing, they have a number of issues. The weaknesses of the Philippine health insurance is that they pay initially by what we call fee for service. This is actually leads, and they allow balance billing. Balance billing is another mechanisms that actually can be very produce adverse effect on the sustainability of the health financing system. They pay capitation at the primary care, which is good. And there was a lot of attempt being made to introduce the DRGs. I was invited to actually develop the Philippine DRGs back in 2013. And I think at the moment, they had introduced a modified version of a DRG, which I think they call it a case payment or case rates. There's still a lot of discussion to actually introduce proper ways of managing the financial resources of PhilHealth. So these are the some of the issues related to the performance of the health financing reform. I think the idea is because of the high out-of-pocket expenditure, and this was trying to be sorted out through the health financing system. And in terms of equity, it is quite good in PhilHealth or the Philippine health insurance system. But of course, there were issues with efficiency because of the initial part they were paying by fee for service, allowing for the balance billing, which is another factor that need to be sorted out. Some of my pictures visiting and working with the social health insurance under PhilHealth a few years back. So by 2013, I think the coverage from 2010 onward, the coverage was actually about 86%. This is repeated. Okay. Let's go into the health reform initiative in Malaysia. I want to discuss briefly on two initiatives which were started in Malaysia. And both of them have got pros and cons in terms of the reform that they do. One of the reform is, which is, I would say, a minor reform, is actually a privatization of non-clinical services. This was started out in 1995 under, at that time, our Prime Minister was Dr. Mahathir. When the first time he came into power, he actually tried to introduce, stimulate the role of the private sector within the public services. And he introduced this he introduced privatization of these services, which actually the clinical waste management services, cleaning services, laundry services, facility engineering maintenance services, and biomedical maintenance services. To a certain extent, this is actually a part and parcel of influence from the World Bank when the World Bank produced a report in 1993 to actually ask countries to explore decentralization and also use of non-government services, which is privatization. The services that was started off by actually providing, by selecting specific companies to actually provide these services. This involves the value of the contract given to these companies is around 14% of the MOH budget. And they actually, the government award this through a non-competitive tender. And this is the big issue. When you have non-competitive tender, there will be a lot of issues. People will have problems in terms of trying to support this because they will have some issues. People question about the favoritism and also cronyism that might occur here by providing this to companies without any tender process or proper transparency in the award. They gave concession up to 15 years with a total amount of being disbursed. At the initial part is nearly about 2.8 billion US dollar. The impact of this is actually, instead of increasing the efficiency, you can see that the government have to cough up quite a lot of money. There's the expenditure on the support services increased in some of the study by 3 times. So from 1996, before the implementation, the government spent 56 million, but then they jump up to 174 million in the day after it has been 1 year after it has been implemented. When we look at the 3 hospitals that are affected, this was a study which was done after a few years of the initiative. The district hospital without specialists, and we also look at district hospital with specialists, and also the general hospital, and we found that there were different outcome of this. The managers, when we talk to them, they actually support the rationale of privatization, But their concern is because when the contract was given to the contractors do not have expertise in some of this area, and they actually leads to a lot of problems. Some of the companies do not have enough staff to carry out the activities, and they were not sort of a comprehensive way of actually evaluating the performance of the contractors, and both sides, the contractors as well as the MOH staff managing this contract, are also in the learning curve. In terms of cost saving, the salary of the government staff that are doing these services have been reduced from 3 to 11%. But however, the maintenance cost has gone up, and then the utility costs are also reduced. So there are some increase and reduction in this. But the cost of professional services they have to pay increased from 170% to as high as 8 times. So this is the cost per bed paid by the hospital is increased to 11,000 to 12,000 depending on the size of the hospital. And the most hit hospitals in terms of the adverse effect of this initiative is actually the medium-sized district hospital. However, when we do the study on the staff perception on the quality, they found that after a few years, the clinical waste provide good services before this, compared to what has not been achieved before. However, the quality in bigger hospital, the quality of service in is quite low compared to a smaller hospital. So, however, in terms of the workload of the government staff has been reduced quite a lot in smaller hospital, but not in big hospital. So the lesson learned from this is that contracting out does not necessarily improve efficiency. Sometimes it leads to the other way around. The efficiency level can go down, and also the quality can be poor. The incentive there's no incentive given to the contractors when the concession was given over a long period without proper way to actually sanction poor performance. And the cost saving that we get is actually being offset by the high charges that are being put forward by the contractors. So it's a mixed kind of situation that we face. This contracting out is still happening today, but a lot of these issues has been looked into, but it has not been totally revised. The reasons for weaknesses in the issues on privatization and the weaknesses is because of the economic theory of market failure. When we give a monopoly to certain contractors and we provide the contract on non-competitive way, a contract will be very long. This might actually lead to a lot of problem. And the other issue is that we actually make mistake by awarding it to companies without technical expertise. What this company do, they end up subcontracting to other companies with technical expertise, but they take a cut in terms of the payment, and as a result, the subcontractors may not be able to provide proper services. There were also issues of poor regulation. For example, the contract was actually poorly written. There were lack of expertise even in MOH personnel to do the regulation, to regulate, to do enforcement. And there were a lot of issues where decentralization was inadequate, and the role of regulating the privatization process was not actually well spelled out. So the other issues relates to who is going to pay for it and how are we going to evaluate this. So we need to have a regular feedback, and this has not been taken up well. So that is the story about what happened to the small initiative. I would say this is the minor reform that was carried out in early 2000 and late 1990s in Malaysia. The other reform that has been carried out in Malaysia, which has not been successful until today. So I'm going to talk about why we failed to actually introduce National Health Financing Scheme. There are a lot of reasons why the country wants to actually reform our health financing system, because we are depending too much on the tax-based system, which leads to high out-of-pocket expenditure. Our out-of-pocket expenditure now goes up nearly about 40%, and especially during this COVID-19 pandemic, things are actually worse. And we are concerned about catastrophic expenditure. At the same time, the services in the public sector were plagued with the issues of long waiting time. There were issues of shortage of drugs, and also brain drain of specialists to private sector, and also brain drain of specialists to work in outside the country. And recently there were a lot of issues facing this, because our neighbor like Singapore, for example, offer quite a big position to doctors from Malaysia to go and work there with a better salary. So all this actually leads to the thinking that we need to do reform. And since 1985, 6 different attempts has been made by the government. This is some of the issues where people have to go to the public to do crowdfunding in order to manage or to pay for the services in IGN. IGN is our National Heart Institute. It's a public institution, but they charge for the services, and people without social insurance or private insurance will not be able to go there. There were issues where people, this is also another plea in the social media and also in newspaper, that this person needs operation, and the child needs to be operated, and they need about 100,000 ringgit. At the same time, there were issues where the hospitals do not have enough resources to maintain. There was a poor upgrade of the hospital facilities, including the buildings and also the equipment. And there are a lot of stakeholders in any country, and Malaysia is not exception to that. When we want to introduce health financing scheme, apart from Ministry of Health, who is the main stakeholder, of course, the population, the employers, the drug companies, the managed care organization, and private insurance are the major stakeholders that have a lot of say and try to influence the establishment of this. What was introduced or tried to be established in early 2000 was actually a hybrid model of combining taxation with a small portion of the population covered by private insurance with a social health insurance program. So this is actually being proposed by one of the committees within Ministry of Health. So the idea is actually to provide or to establish an intermediate body, which is called National Health Financing Authority, which is more or less the same like the BPJS in Indonesia, which is appointed by the government. The source of funding will come from the insurance plus the premium, and then the private payment mechanism that was actually going to be adopted will be global budget, case mix, and also capitation with a small fee for service. This so-called one care plan was actually being started off as an idea. In 2010, many press statements were made by the government, and of course there were complaints by some of the stakeholders that the Malaysian Medical Association complains that they were not being properly or adequately consulted. And of course, researchers like myself over there in 2011 do provide some input on how to actually encourage to establish a proper system, which is one care. However, there were a lot of complaints, and one of the major issues was that people thought that we are not ready to implement this because of many other reasons. So the Minister of Health at that time announced that they finally retract the idea, and it was not implemented. And until today, some of the attempts are still being made. Why is it the reform failed? Because number one, there's a lack of political will to pursue the reform. The governments are being heavily influenced by many parties, especially the private insurance and also the employers who do not want to actually co-pay the premium. There is technical witnesses in the team that wanted to actually lead the reform activities, especially the staff in Ministry of Health may not be properly trained to conduct to undertake the reform. Information issues. There were also fightings over who actually to control the agency within the government. The EPU, which is the strong body that actually influenced the privatization activities, wants to control the program. MOH also want to take a major role. So this actually leads to a lot of problems. The potential losers, such as the private insurers, they fight quite a lot so that the program will not be established. And this is actually leads to many other problems. So we actually recorded this in the Lancet publication in 2011. We document this when we were looking at the various health financing issues in the region, and it was one of the case study was looking at the failure of the country to introduce social health insurance. And finally, what the government do? The previous government, which actually lost in the previous two election, tried to introduce voluntary health insurance instead of a compulsory health insurance. The idea is that for people would be able to choose if they want to come in or not. The strength of this is that it will be acceptable to the population to come in, and then people will not be forced, will not be mandated. But this is again very different from the social health insurance program, which actually most of the time have to be mandated to ensure that we will not actually lead to adverse selection. And so the weaknesses of voluntary health insurance, which was proposed, of course, might lead to adverse selection. The premium might be too high for people to join in if the pooling are limited to those with high risk and also high cost conditions that are going to be suffered by people who are high risk. So the lesson so this actually leads to nowhere, and this voluntary health insurance was never being implemented. So we are back to status quo in Malaysia, which is actually issues that are still being discussed today. There's a new initiative now being debated, and I think the chances that we might be able probably in the future to relook at all these issues. So all these reforms that I mentioned in the 4 studies that we briefly touched, there are certain things that we can learn from this system. Number one is that if we are doing a major reform, it is very challenging and it requires many conditions. And some of these conditions are outside the health system. For example, we need political will, we need a stable government, and also we need time, and that is very important. Number 2 is that you need to actually look at, when we do major reform, the health financing reform, we have to look at what is already being established. So the old institutions. So Malaysia, for example, populations are very sort of used to the low amount of payment, that almost free services when they go to the public facilities, and they are paying tax. So they do not want to be re-taxed with another kind of social insurance program. Minor reform can easier be done and higher chances of success. But minor reform, like for example, the non-clinical services in Malaysia, is being done for 5 different services, but the chances of success is there, but there are also a lot of other problems that are happening. But much of the problem with the minor reform can easily be tackled. Devils is on the details. This is where once you go into the detail, there are a lot of things need to be sorted out. However, many countries are still having no clear model, and we have to see what is the right way to do that according to the situation in each country, and this might be different from time to time. It is also important to have sufficient information and strong analytical tool whenever we want to move forward to do reform, to actually solve some of the problems that are happening in the country. So this is very important. If we do not have information, and we do not have analytical tool, and we do not have people who are actually capable of managing the reform, it may be difficult to be successful. So in conclusion, the current health system is being challenged by changes in epidemiology, social, political, and economic situation in the country, in each country, in developing countries. All these are the same. Reform that should be carried out should actually be able to improve equity, affordability, accessibility, quality, and we must also try to have a proper and appropriate mix of public and private sector involvement. And of course, health financing and economic issues will still be a major focus in the health system reform in this century. So thank you so much. I will stop here, and thank you for listening and for attending this lecture. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Prof. Aljunid, for your interesting lecture. And based on Prof. Aljunid presentation, that we can conclude that the health system reform, it will be changed by the knob like governance, financing, health worker workforce, and health information, medicine, and technology. And then Prof. Aljunid also give an example in Mexico, Vietnam, Philippines, and Malaysia, and he give more detail in Malaysia. And the health financing reform in the 21st century will be in the health financing and economic focus. So now it's time for discussion. And in the chat room, it's already about 5 questions. I will read 2 questions first, and then after that I will ask the participant to ask directly if the participant want to ask directly. So Prof. Aljunid, the first one is from Dr. Hidayah from Kuala Lumpur. Just want to ask what's your perspective on pay for performance system for healthcare personnel. Do you think will boost their motivation, or will it cause more stressful environment?
Thank you, Dr. Hidayah, for very interesting question. Pay for performance theoretically is one of the ways that can be implemented if we want to actually motivate healthcare staff, especially in countries where the healthcare staff are getting very low salary, or there is a big gradient difference between the public and the private sector salaries. However, there are 2 issues that we are facing when we want to implement it in developing countries like Malaysia, for example. Number one is that the issues of trying to get proper mechanism to implement this within the health sector. And in most countries, health sector is with the Ministry of Health is part of the other ministries, and the government, the staff are actually civil servants, and civil servants, they will follow the overall civil servant structure. So in order to introduce pay for performance, you cannot only introduce it in the health sector. You might have to actually reform the whole civil service. So that might actually put a lot of difficulty on that. Number 2 is that how are we going to monitor this pay performance? I think Malaysia tried a small way to do the pay performance by providing some incentive. For example, they provide some bonuses or salary increment based on performance. But the way that this was implemented is not very smooth. There were a lot of issues where people accuse the bosses that they were not being evaluated properly. So the tool to actually do the assessment need to be properly developed and accepted by the employers. Whether this cause more stressful environment, of course, you need stress to a certain extent to make people work, but we do not want people to only focus on the on actually their performance that are being evaluated by the system, and this actually will neglect other services. So this is something that need to be carried out. Yes, there were other countries, some countries that are very successful in providing pay for performance, but there were a lot of implementation issues, both from the recipient, which is the employees, and also the employers that are implementing the system. I hope that will help to answer the question. Yeah.
Okay, thank you, Prof. Aljunid. I think it's also the same situation in Indonesia, like pay for performance in the primary healthcare. Yeah, it's sometimes stressful also. Okay.
Yeah.
Yeah. Okay, and then the second question, Prof, is from Sumarti from Indonesia. I want to ask one of the obstacles to public health services in the health insurance participation, especially for the poor. Currently, in Indonesia, implementing a national health insurance system that accommodates health insurance for the poor. In its implementation, this activity requires a very large budget, so that is burden regional finance. My question is, what system should be put in the place to address this problem so that the community gets health insurance, but does not burden local finance? Thank you.
Yeah. Thank you, Sumarti. I think you are well aware of the situation in Indonesia with the Jaminan Kesehatan Nasional. I think as the example that we discussed in Mexico and also in Vietnam, where they introduced insurance for the poor within the social health insurance program, I think Jam Kesmas in Indonesia has been absorbed into JKN, and the poor are now they don't have to pay any premium. The government pays for it, but the issue is that it will lead to actually quite high burden to the government, especially if the people who declare themselves to be poor have not been properly vetted through. So if you have you need to reduce these issues so that the government will not have to bear all the very heavy expenses, is actually to have a very strict rule on how to decide whether they are poor or not. So the exemption mechanism for payment of premium need to be scrutinized, need to be implemented properly, so that there is no people who actually abuse the system and be free riders. They declare themselves as poor, but they are not poor. So the population of the instrument to actually assess whether people who are poor or not must be properly developed, and it must be properly implemented. This will actually help to do that. It's not easy to solve this problem. Many countries are not able to do that. In Mexico, for example, the family are supposed to pay a small premium. Nobody pays at the end of the day. So the whole thing is under the government. I think in Indonesia, the poor also does not pay any premium. The government are the one who pays for it. But there are issues where those who are non-poor using the kartu for the poor, and that is something that need to be sorted out. So you need to have a very strong enforcement mechanism to actually detect these abuses by the population who are actually not ethical enough to follow the proper regulation.
Okay, thank you, Prof. Aljunid. Maybe I will ask for participant to ask directly. Anyone want to ask directly? If yes, please.
Dr. Jatila, there is one more question which was posted in the text by Dr. Nur Hidayah.
Oh yeah, okay, yeah, yes, Prof.
Do you think the recommended 6% of GDP for healthcare expenditure is ideal? I think the issue of the amount of resources that goes into health sector has been widely debated. What WHO was quoted to be suggesting is 5%, although WHO said that this is not their official stand. They say that this is actually being discussed or being proposed by consultants working for WHO. So there is no real what we call proportion of GDP that should be allocated for healthcare. But if you look at the international benchmarking, we do international benchmark. The whole world is spending around 10% of the GDP, and then OECD is around that 11% of the GDP in most of the OECD countries. So I would say if you are talking about 5% or 6%, this will not be enough. So probably we need to increase to a figure which is near to that. When I was doing some health sector review in Malaysia a few years back, I suggested that we should at least increase our healthcare expenditure allocated for health to at least double what we have now, from 4.4% to nearly about 8% of the GDP. But again, it is not only the amount that goes, but the way that you manage it. It must be targeted toward a proper part of the services. If all are spent, or 90% are spent on curative, it's not going to solve the problem. The important thing that you have to balance between the preventive and curative services, where the curative services are normally more efficient and will give a long-term effect, more lasting and sustainable in terms of the outcome. Okay. Yes, Dr. Jatila, I pass the floor back to you.
Okay, thank you, Prof. And the next question is from Rizky Habibah Rahma from Universitas Negeri Semarang. How is the strategy of countries that have been success in the carrying out health reforms in maintaining this reform in the first 5 years of reforms? And what are the challenges and obstacles in maintaining and enhancing the health system in these developing countries?
Yeah. I think if you look at again some of the success stories in a few countries that in our case study and also in other countries that we have observed, we can see that one of the way that this country was successful in initiating the strategies is that they are very focused and they have a very strong technical team that support them to carry out the activities. To reform, and at the same time they are very flexible in carrying out some of the changes that occur. Remember, one of the lessons learned is that devil is in the detail. So whatever that we plan in the reform, when we go for the real implementation, we have to change it. We have to advise. So you need flexibility. So some of the ingredients that we need is that you need to have a very strong government that are forward-looking. You need to have a quite a good technical support team, and you must be flexible to be able to change what you have planned before to something that is better if we face a certain problem. So I think Indonesia is the right track now with the JKN. We started off with a payment method that was actually that does not promote supply-induced demand. Like for example, we are using capitation for the puskesmas, and then and case mix for the inpatient services. But still, there are a lot of other things that need to be sorted out. For example, we need to sort out in terms of getting the poor to be properly registered and to prevent leakages and also abuses by the system. Every health financing system that introduces, there are always mechanisms that leads to moral hazards, and these moral hazards, which is abuses by the providers and also by the population, need to be controlled. So all these have to be put in place, and you must have a strong and stable government, and also you must have some flexibility in introducing the changes if we need to after the evaluation. I think in short that's what I can offer my views here.
Okay. Yeah, thank you, Prof. And the next question is from Hasya Milati, Hanifah, Universitas Negeri Semarang. What's the difference between reforms in developing countries and developed countries? Is there anything that can be implemented in developing countries from the reform of the healthcare system in developed countries?
Yeah. Thank you again for asking this question. If you look at the overall difference between the developed and developing countries, major reform, which I mean here is reform in the health financing system, has been carried out by developed countries much earlier than what we are trying to do here in developing countries. For example, social insurance program was introduced in Germany. Germany is the first country in the world that introduced social insurance program back in 1893 under Chancellor Bismarck. So they started quite early, and then after that, in the early century in the early 19th century, there were in the early 20th century, countries in the European region have started off with the social insurance program quite early on. In US, for example, starting from in the early 80s, they already established this. So developing countries is actually very slow to actually start off with any form of reform. So, but we can learn a lot from developed countries. Whether developed countries can learn from developing countries, of course. I think a lot of changes being done in the developed countries are also by looking at the examples of success and failure in developing countries. I think both regions or both type of countries can learn from each other. But obviously, developed countries have more experience. They have more data that they can play with, and their way that the governments are managed in this country, the government system in this country are quite different. They probably have a more flexible government than many of the developing countries. Yeah, that's back to you, Dr. Shatila.
Okay, thank you, Prof. And there's one participant that already raised hand, Hasmira Basir. Maybe you want to ask directly to Prof. Aljunid. Okay.
Yes, Hasmira.
Assalamualaikum warahmatullahi wabarakatuh. I am Hasmira Basir from Semarang State University. So here my question. As we know, during the COVID-19, the health system in developing countries is experiencing difficulties, and this makes the country have to think about what they have to do to make the health system continue to run well. According to Professor, what should the developing countries do so that their health system can run well during the pandemic? Thank you.
Yeah, it's very unfortunate that the COVID-19 pandemic hits us in 2020, actually December 2019. I think this we cannot avoid this because there are a lot of things happening in the population, and then the change in the behavior of the population. At the same time, the risk factors within the population are also changing, and people are doing a lot of risky behaviors. But there are some good things that actually happen, or the positive part of the COVID-19 is that we give a lot of attention to health sector. Before this, maybe the government are not focusing so much, but when we are hit by one of the worst pandemic that we have in the century, I think until today we have reached 5 million deaths all over the world, and nearly about 250 million people are affected worldwide. Indonesia and Malaysia, for example, suffered quite a lot. So I think we, to a certain extent, health sector used to receive inadequate funding. But for example, in many countries now, the government are putting a lot more effort to actually provide increase in the funding. We can see some increase, but in Malaysia, the last budget was not very good. The funding was not actually increased so much. But a lot of this funding was actually targeted towards a short-term measure to buy vaccine, to buy drugs, new drugs that are going to be saving life for people who are in category 4, category 5 of COVID-19 infection, for example. So I think this is important. And one more important aspect that we can see is that in many countries, the government start to open their ears and their eyes to hear and to see the importance of preventive services. So primary prevention, like vaccination, for example, is given a lot of effort now, because we know that so these are some of the issues. I think although a health system was hit quite badly by COVID-19, there are some positive effects to the health system that we need to take advantage of in order for the health system to survive and sustain in long term. I think that's what my response to you, Hasmira.
Okay, thank you, Prof. And then, yeah. And this there are 4 questions more. It is okay, Prof?
Chatila, was it okay?
Yeah, I'm okay in my set. Okay.
Okay, go ahead. Yeah.
Okay. Yes, from Putri, from Universitas Negeri Semarang, I would like to ask you about the hybrid models toward building a good health financing in a country. It is being able to implement it in every country, especially developing ones, regardless of their priorities.
Yeah. Yeah, the hybrid model that we showed, which is the one care system, is not being able to be implemented in Malaysia, although the theoretical framework is there. Because of some of the problem. One of the things that we face in Malaysia is because of the lack of political will and all the other issues, including the strong objection from the employers and also people that are going to pay for the premium. Whether this can be implemented in other countries, I think is difficult to say. But I think in most countries, there are already existing hybrid model. For example, when you implement JKN, you have the contribution from the premium for people who are actually working in the formal sector and also informal sector, and there is also government budget that are being from the taxation that are covering the premium for the poor. So, but it's already there. But what have not been probably demonstrated or being seen is the role of the private insurance. They may not come formally. At the moment when it is very difficult to actually merge these two systems, the public and the private insurance, because the private insurance work on for profit. And when you want them to participate in the social health insurance program, they have to change the way that they operate. For example, they cannot operate on looking at the risk rating ways of charging people for the premium. In social insurance program, we do not use the concept of risk rating. The risks are shared with everybody, and then you pay one premium depending on other factors, not the risk of having the diseases. So hybrid model will have some limitation, especially when we want to bring in the private sector to be involved in the formal program. And this is something that we need to think about, and I think it's difficult to actually implement this without a proper regulations and also legal framework that actually support this.
Okay. Yeah, thank you, Prof. Okay, and then other questions is from Liliana from Institute for Health Management Malaysia. I would like to ask your opinion on regionalizations of hospitals for healthcare deliveries. If you have heard about cluster hospital initiative in Ministry of Health Hospital in here, I'm curious of your opinion on its sustainability.
Yeah. When we say regionalization, is the very good example is what happened in Singapore, where the hospital not only being regionalized, but they are also autonomous in nature. This is the way that the hospital actually operates. They were given a lot of freedom. The management of the hospital would be able to actually introduce the services. They were able to introduce pay for performance. And then a lot of initiatives to increase efficiency and quality are being left out to the hospital to be innovative. In Malaysia, when we talk about cluster hospital, this initiative is just touching the surface of what I have in my mind when we talk about regionalization. It's very different from what is being done in successful countries that have got this autonomous hospital concept. So I think there's still a long way to go. You need to have a proper health financing system to be put in place. You need to actually review and reorganize the mechanisms of the hospitals being managed in Malaysia if we really want to go into a proper regionalization. What I have in mind is that the regions managing the independent hospital, there is an authority within each region, and the regions will actually compete with one another to show that they are to produce efficient and effective services. So it needs a lot more tweaking to the system. It needs a lot of changes to the overall structure of the Ministry of Health if this were to be implemented. Cluster hospital initiative is not actually a regionalization concept that we have in mind when we discuss this in the forum in Malaysia.
Okay, thank you, Prof. And there are 3 last questions, I think. And this is from Asisa from UNES. Asisa Sabila Yasari from UNES. I want to ask, we know that the whole world is having facing COVID-19, and I think it's affect a health financing that may be diverted in COVID-19 for vaccination, treatment, PPA, etc. It's any financing for this based on their health system, like Vietnam and other countries that may be given for full people, but COVID-19 affect general. Okay, could this factor in health reforms?
Yeah, this is a very good question. Whether the COVID-19 is actually one of the trigger points. I mentioned earlier on, it might be one of the important trigger points for the reform. This is the second year that we are having this COVID-19. A lot of attention are given to Ministry of Health and also to health services in the country. And then what we see now, there is initiative of the collaboration between various sectors, not only Ministry of Health, but Ministry of Health work together with the other ministries such as the Ministry of Education, Ministry of Higher Education for the research component. They work together with the universities in the research component. It is actually an important trigger point. But 2 years over the line, I have not seen a more elaborate kind of reform. I was hoping that health financing initiative in some countries will be reviewed in order to do this. I think in Indonesia, you have tried to establish the payment method for the COVID-19 cases, and by creating a special mechanism to pay for this before it was paid separately outside the your JKN. I think there's maybe a small reform that has been carried out, but we need to see whether COVID-19 will be able to bring in major reform in the health system. Especially, I'm looking at the health financing system. I hope that this will happen. But so far, I think not much sustained activities has been carried out to change the system, just stimulated by the COVID-19 situation. Of course, there are budget allocated for the drugs and all that, but this must be a short-term thing, I think.
Okay, thank you. And then the next question from Dr. Sikin from Ministry of Defense Malaysia. How do you view the use health information system in reforming Malaysia healthcare?
Yes, Dr. Shikin, very interesting question again. As I mentioned earlier, why is it we are not able to actually reform our system, our health financing system, after the last 6 attempts? One of the issues is that we do not have adequate information. If you want to actually reform the system, you must have a good information system. The problem in Malaysia is that the health information system not only inadequate in terms of the content of this of the information, but sharing of information between different parties is not being the practice. For example, when the earlier part of the pandemic, people in the universities, the researchers are crying because they do not have information that are detailed enough shared by Ministry of Health for them to give their views. So I think apart from having a good information system is one of the necessity in reforming the healthcare system, but we also must look at the way that health information system being governed. There must be a mechanism where the system allows sharing of information between various parties so that everybody can contribute to improve the health system in the reform. I think that's in short what I can respond to you.
Okay, and then the next question is from Jay from North Celebes. My question is, what is the ugliness of the healthcare information that could be accessed many people? Thank you so much.
I cannot. It's not clear. What is the question?
The ugliness of the healthcare information that could be accessed many people.
Oh, here,
yes.
the ugliness of the healthcare information that could be accessed by many people. I think what it means here is that what are the weaknesses and the drawback when information can be accessed by many people. Of course, when we want to access health information, we want people to be responsible and to use it ethically. There are a lot of information that can be shared, but does not actually leads to this. For example, when I say sharing of information, does not mean that sharing of personal information. So we can actually we do not have to be to expose all the identity of the patient that if we want to actually share this information. If we don't share, then you'll have problem where the information cannot be used for decision making. But if you share it, you must share it responsibly with a proper and ethical way of managing this information. I think that will solve this problem.
Yes, thank you. And then this is the last question, Prof. From Nabila, Jabatan Kesehatan Kuala Lumpur. Malaysia currently introducing My Salam Takaful with the private insurance company Great Eastern. Currently, it only covers the B40 and only from government fund. Do you think My Salam in the future will expand to cover M40 with some premiums? Do you think this system can go further in the future and have benefit to government?
Yeah. In my talks, I think in a different forum, I've given my views on this My Salam Takaful. This was introduced by the previous government that lost power recently, the Pakatan Harapan, which is actually a short way or a brief way of trying to actually solve the problem when voluntary health insurance, which was trying to be pushed by the government before that failed. To me, My Salam is relatively quite good initiative to start with, but it is very limited to certain in certain ways. Number one, it is linked to private insurance, and it is very difficult for the private insurance actually to work well, especially when it is linked to the private insurance companies that have got of interest. And we must know that the money that is contributed by the private insurance to this scheme is actually the penalty that they pay for flouting certain rules in terms of the distribution of shares. But this is actually the way that the program is being managed. There are a lot of difficulties, a lot of problems. It has to be managed properly. Currently, there's lack of transparency in terms of the budget that was allocated from the penalty that was actually paid to be paid by the insurance company to this package, and the type of services with there's a lot of cappings there. There's a lot of problem. So I think this system have to be revamped. The system cannot be sustained in long term. It will not actually it will fall short of what we want in the proper social health insurance program that will cover all the poor and also the non-poor in the country.
Okay, thank you, Prof. Aljunid, and I think it's the last question. So, yeah, we have many questions and also a good explanation from Prof. Aljunid. And now it is the end of this lecture. And but before we close this lecture, I will give you the link for certificate. It is in the chat, already in the chat room. Okay. And also, please write your email address correctly, and the e-certificate will be sent to your email address. The link is active for only 60 minutes after this webinar is over. Okay, and thank you so much, Prof. Syed Aljunid. Thank you for give us a lecture. This lecture is very interesting. And also thank you for all the participants. And I think it's the end of our lecture. And thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Prof. Syed, for very interesting discussion. Thank you very much, and our colleagues from Malaysia. Yeah. Thank you.
Yeah.
Thank you so much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Yeah, thank you, Prof, and thank you for all participants also from the Malaysia.
Yeah.